For decades, clinical medicine treated atherosclerotic cardiovascular disease as a sudden mechanical wear and tear of old age, a problem that only begins when the chest pain starts. But longitudinal research shows this is a life-course metabolic progression. While clinical manifestations like myocardial infarction or stroke typically appear in middle or late adulthood, the silent incubation of these conditions spans decades. The damage accumulates quietly, long before the first symptom occurs. Post-mortem investigations and epidemiological cohorts identify the earliest stages of human existence as the starting line. The foundations of cardiovascular pathology are established in infancy. If vascular foundations are laid in the first weeks of life, do infants require pharmacological lipid management? Do babies need statins? Atherosclerotic cardiovascular disease is an incubation disease. This means the most effective window for altering its trajectory occurs before a patient can even speak. The cardiovascular clock begins ticking during fetal development. A child's initial arterial health is heavily influenced by the maternal environment in the womb. Maternal hypercholesterolemia, abnormally high cholesterol in the mother during pregnancy, is associated with accelerated early atherogenesis, or the formation of plaques, in her offspring. This occurs through the altered epigenetic regulation of SREBP2. SREBP2 is a protein that acts as a master regulator for the genes responsible for synthesizing and absorbing cholesterol. Epigenetics refers to the chemical markers that turn these genes on or off without changing the DNA sequence itself. This epigenetic imprinting is physically linked to the presence of early fetal atherosclerotic lesions. The metabolic environment of the mother creates a physical record in the child's vascular tissue. A child's lifelong cardiovascular health is not a clean slate inherited at birth. It is environmentally imprinted in utero by the mother's metabolic state. At birth, cholesterol concentrations in umbilical cord blood are substantially lower than adult thresholds. This low lipid state is a brief, temporary metabolic phase. The neonatal period triggers a rapid metabolic transition, as shown by the Copenhagen Baby Heart Study. This dataset tracked the lipid trajectories of over 13,000 infants. This chart shows total cholesterol progression from birth to 2 months. At birth, the median is 77 milligrams per deciliter, rising to 147 in 8 weeks. Atherogenic traits continue this climb. Low-density lipoprotein, or LDL, stabilizes at near adult levels by 14 to 16 months. This rise creates a nutritional paradox. Breastfed infants often show higher cholesterol concentrations than formula-fed peers. This is a physiological response to the cholesterol-rich composition of human milk. While atherogenic particles rise, non-atherogenic traits like high-density lipoprotein, or HDL, fluctuate. HDL rises initially but declines as the infant transitions to a mixed solid diet. Infant lipid levels are not static. They follow a programmed physiological escalation that establishes the body's metabolic baseline by the time a child learns to walk. Why does human biology drive lipid levels so high during infancy if cholesterol is a leading cause of mortality in the modern world? High circulating cholesterol provided a survival advantage in ancestral environments. These genetic variants provided energy security during cycles of famine. Cholesterol also serves an essential immune function. It organizes into lipid rafts, dense clusters on the cell membrane, that group antigen receptors together on memory T cells. This allows an infant to mount a faster response to infection. High-density lipoprotein also acts as a scavenger. HDL particles bind and neutralize bacterial toxins, such as lipopolysaccharides, during an active infection. Beyond the immune system, cholesterol is the obligate precursor for steroid hormone synthesis. It is required for the production of cortisol, which is essential for adrenal stress adaptation. This is a case of antagonistic pleiotropy. This is a biological concept where a specific trait provides a survival benefit early in life, but causes severe health costs as the organism ages. The metabolic traits designed to keep infants alive in harsh ancestral environments now provide the foundational fuel for cardiovascular disease in a world of caloric abundance. Shifting from evolutionary theory to hard pathology, we can see the physical impact of this high cholesterol baseline in young arteries. The PDAY study, Pathobiological Determinants of Atherosclerosis in Youth, examined the arteries of nearly 3,000 individuals aged 15 to 34 who died of external causes. The researchers looked for fatty streaks. These are subintimal accumulations, where foam cells and immune lymphocytes gather beneath the inner lining of the arterial wall. The PDAY study showed coronary and aortic lesions consistently present in adolescence, transforming into raised, fibrous plaques. In these youth cohorts, the severity of these lesions correlated strongly with modifiable risk factors like blood lipid levels. Risk scoring derived from these youth autopsies accurately predicts the presence of coronary artery calcification in middle age. While pediatric lipid profiles improved between 1988 and 2010, the modern obesity epidemic is now amplifying adverse lipid phenotypes in vulnerable pediatric subgroups. Autopsy data shows that the physical construction of a middle-aged heart attack begins within the arterial walls during childhood and adolescence. To understand this risk, we have to move past single time point measurements. A single cholesterol check in adulthood does not account for the decades of silent accumulation that preceded it. The driver of disease is the lifelong cumulative arterial exposure to atherogenic lipoproteins. This chart uses the area under the curve model to track this cumulative burden. The x-axis represents age, while the y-axis tracks LDL concentration. The shaded area underneath the trajectory line represents the total volume of atherogenic exposure the arteries endure over a lifespan. As plasma cholesterol rises with aging due to reduced LDL clearance, the area under the curve expands. This growth matches the physical progression of arterial lesions, from a streak at age 15 to a fibrous plaque by age 40. Plaque formation is a mathematical function of time and volume. The longer arteries are exposed to high LDL levels, the greater the irreversible vascular damage. Given this accumulation, do babies need statin therapy? No. Pharmacologic therapy is reserved for older children with severe genetic dyslipidemias, such as familial hypercholesterolemia. This chart shows the pediatric lipid thresholds used by clinicians. For children aged 2 to 19, an acceptable LDL level is below 110 milligrams per deciliter. Screening guidelines recommend a universal check between ages 9 and 11, with targeted screening beginning at age 2 for high-risk families. This early period is the window of opportunity. This is the mandate of primordial prevention, intervening during the developmental window when vascular injury remains minimal and highly modifiable. The foundation of this approach is the cardiovascular health integrated lifestyle diet, or the Child 1 protocol. Interventions include exclusive breastfeeding, delaying solid foods until at least 4 months, and transitioning to reduced fat dairy after 12 months in appropriate contexts. Viewing atherosclerosis as a pediatric origin disease allows for the optimization of a child's earliest nutritional environment. This alters the trajectory of cumulative risk before the first plaque ever solidifies.